Very good evening, everyone. On behalf of IAP India technical team, I, Dr. Jaspreet, welcome you all. Firstly, I would like to welcome our today's speaker, Dr. Pearlson sir, and our today's moderator is Dr. Soumya Chatterjee sir and Dr. Upanita ma'am. Before over to Dr. Soumya sir, I request all the participants please like and subscribe IAP India YouTube channel for watching all online webinars. Over to Dr. Soumya Chatterjee sir, please moderate the session. Thank you.
Shall I start?
Yes, sir.
Yeah.
A very good evening to all of you present here. Myself, Dr. Soumya Chatterjee, Secretary Tripura State Branch. Welcome you all in our today's free webinar being organized by Tripura IAP State Branch. Here, I will take a moment to express my greetings to Central IAP, Dr. Sanjeev Jha sir, Dr. Ruchi Madam, Dr. Annamalai sir, Dr. John sir, for providing this wonderful virtual platform since lockdown days. Today, the topic of webinar is manual therapy techniques for thoracic spine. And our resource person is none other than esteemed professor and stalwart of our arena, Dr. Pearlson K. sir, founder, Federation of Indian Manual Therapists, faculty, Padma Shri Institute of Physiotherapy, consultant, Padma Shri Diagnostics, and Joint Secretary, IIP Karnataka branch. It's extreme honor for us, sir, to have you today with us, sir. Dr. Pearlson, sir, he graduated from MGR Medical University of Health Science. His interest in manual therapy resulted in the completion of his post-graduation from University of South Australia, Adelaide, in the year 2000. He had extensive training under David Butler, Mary Jones, Mary McGarry, Toby Hall, Jenny McConnell, Jenny Roberts, and teaching experiences in different areas of manual therapy with emphasis in joint mobilization and soft tissue techniques. He is the member of International Myopain Society, member of International Allied Health Profession, and American Physical Therapy Association, APTA. Internationally recognized instructor, K. Pearlson sir has taught concepts of clinical reasoning and integrated manual therapy in 45 cities in India and abroad. He taught more than 10,000 physios about manual therapy, and very fortunately, I am one of them. Sir, without taking much time, I am handing over the screen to you. Before that, I would like to request today's attendees during this session or talk, if you have any question or doubt, please write it in the chat box. We'll pass the questions to our resource person at the end of sessions. Thank you, sir. You may proceed, sir.
Yeah, thank you. Thank you, Dr. Jaspreet, and thank you, Dr. Soumya, and Dr. Birbar, and all the CEC members of Tripura. And my great thanks to our IAP National CEC and my president, Dr. Iftikhar Ali, for giving us opportunity for us to, share our knowledge with you all. Good evening once again, and thank you for inviting me here. So I'm going to share the screen now. Fine. So today's topic is about manual therapy techniques for thoracic spine, because we always look in our lumbar region. So we had an interaction with Dr. Birbar, and we thought about, okay, so we will likely to have more on something which has not reached to all the people, and we thought about thoracic spine could be a better opportunity for me to share my experiences, and as well as for everyone to explore the same. So when we say with thoracic spine, the first the cardiac region. Okay, so if you think about thoracic spine, musculoskeletal, the first region which we need to think about is the cardiac pain site. Okay, so that is the foremost thing which we need to consider before we think about the musculoskeletal or trying to do a manual therapy or a mobilization for the same. So you could see here the dark red color, which tells you the more painful area, and it's not only that, and the other regions also you can have the pain. So the dry, like the light red area. So on the posterior, you can see here the upper thoracic region, where you have like a T2, T3, or T4 level, and it covers the neck and as well as the cervical region, which could be due to the cardiac pain. So I would request or I would tell to everyone saying that, like if anybody comes with a cardiac, or if anybody comes with a thoracic pain, so let them be scrutinized properly, or let them be reasoned out properly before we think about doing a manipulation. Because when I learned manipulation, so the first thing, the easiest part to be manipulated is the thoracic region. So always we give a try of doing the thoracic rotation manipulation. But at the same time, like we have to be very cautious. So today as well, we have to look at what are the structures, or what could be causing the pain, or what could be causing the discomfort when the patient comes in. So please don't forget, the people with pain on the left side, it can radiate down, or refer down to the arm and the forearm when you have a cardiac involvement, and which is very, very important for us to look in before we consider that, okay, this is our physiotherapy treatment patient, or this patient fit for physiotherapy. So this is the pain site all of us really need to look. So looking in the anterior aspect and looking in the the posterior aspect here. And the next region is about the visceral pain site. Okay, so before you conclude as a musculoskeletal, we really need to rationalize, and we really need to kind of eliminate all these things which is not there in the patient. So the structures which we all know, like so it could be, as I told you about the cardiac, which can cause us pain down the arm and the forearm here, and gallbladder or liver, which can cause us pain on the right side, and the lung and the diaphragm, which can cause us pain on the left over, and as well as the other organs, so which we have, which could be causing the discomfort around this thorax region. So it's very, very important for all of us to consider and think about the visceral pain or visceral organ. So you really need to have a the eliminate through a physician, or through a surgeon, or somebody else, to eliminate all this thing before we do a manipulation. Because one of the other thing is, like when they have a multiple system impact or multiple system failure, so when you try to do the manipulation, it can break. So we have to be very cautious, and we have to really ascertain saying that, okay, it's not involved. So as I look back, one is a cardiac. Don't forget to look into this. And the second one is the visceral. So before we get in, like saying that, okay, what could be the reason for our musculoskeletal pain. So this is one of the patient which we have come across, saying that a typical thoracic pain, so which has pain on the thoracic region. So exactly over the thoracic region, and no other symptoms, and it is mechanically driven. So movements, which causes the pain. So which is quite easier for us to understand that, probably this could be the patient for me to do a mobilization or a manipulation, or something else. So rather than trying to do a manipulation for someone who has a pain in the anterior region, or as well as a posterior region, so which we have to be very cautious. Okay, right. So when I say, like, whom do I choose, or whom do I get with the thoracic region? So the first one is postural thoracic pain. So someone comes with postural thoracic pain. So it could be like, because of long sitting postures, or because of lying postures, or because of, any kind of particular position for a longer period of time. So which could be leading into the postural thoracic pain. So which is quite easier to target with, or quite easier to deal with. And people we will come across, could be due to the mechanical irritation of the sympathetic chain. So mechanical irritation of the sympathetic chain can also lead into causing the pain. So that is also causing the discomfort or the sympathetic nervous system. So like, palpitation, temperature changes, and sweating changes, which has to be looked upon, or which has to be asked. And apart from that, we see a lot of people with dynamic muscular control of shoulder girdle, like, people with rotator cuff injuries, having a thoracic spine involvement, a neck pain, having a thoracic spine involvement, and you would have come across with a costal joint involvement, like, costal costochondritis, where we can do a bit of mobilization, possibly, like, we can try to help the patient a lot. And at the same time, with post-operative musculoskeletal pain patients, like, those are done, lower limb surgeries, or any other regions, where we need to really look, because of the position in which they adapt for a month or 2 months or 1 month or 3 months in the lying position, which also can lead into the, thoracic pain region. So these are the possible thought process. So I would say, like, clinical reasoning or hypothesis making. If we try to adapt that, like, when you look in with this patient, so if we had a pain here, so what could be the reason? So it could be the straight away the bone, or is that the joint, or is that the, musculatures, or is that the referred pain somewhere, it's coming from the cervical or somewhere else, which we need to think. So we need to make a good working hypothesis. If at all we get first contact practice, we need to eliminate they don't have any other structures, the prominent structures like a visceral or cardiac, they don't have impact. So if they don't have that impact, straight away we can look into that. And you could see here, it's very interesting, which we need to, remember, like, what are the other possible, or what are the other things which can cause us referred pain to the thoracic region. So that's the reason why I'm stressing you more, saying that, we really need to eliminate the visceral conditions or visceral regions. So myocardia can cause the discomfort, and these are the few things, which we need to remember. Like, that's what we say as a clinical pattern. Okay, so at least I should know that, right, what kind of questions or what kind of things I should ask the patient to come into a conclusion, saying that, okay, this fellow is a little bit of a red flag, so I should not be doing a mobilization, or I should be sending him to a concerned specialist. So like known clinic exercise, pain not reproducible by palpation, because which is very important, like, when we palpate. So when we palpate over the spine, so when you palpate over the spinous process, or the transverse process, or any other region, they should be getting the pain, which is not possible. And patient believes that, it's a more of a cardiac origin. So that's one thing which we need to look. And thoracic aortic aneurysms, which can be understood, and which doesn't change with the positions. Like, that's what the typical thing which we look at with the mechanical pain, like, more positions increases the pain. So it doesn't change that. So that's a very, very important thing which we need to look. And the peptic ulcers, pain referred to the mid-thoracic spine. Pain changes after eating meals. So if someone says that, like, after eating meals, I have this discomfort, so we really need to look in. Or if they have indigestion along with this, which we need to look upon. Okay, so definitely it's not our case or our thing which we need to look. And then we also talk about, cholecystitis. The pain in the right upper abdominal quadrant can refer pain to the right scapula. and they will have nausea, vomiting, fever. So if someone says that I have these features, you are thinking that maybe some red flag. So you are not going to do a manipulation or a mobilization for the patient. And neoplasms, as we all know, like unexplained weight loss, or they don't get better after any kind of a treatment. Then inflammatory pathologies like ankylosing spondylitis, which which will have a stiffness, which is a big cardinal sign of which indicate about the ankylosing spondylitis. So you really need to ask them, if they have any kind of discomfort because of the pain. And as well as it does affect other joints like SI joint and other things, so which we should be aware of, like what are the joints which is affected for the person along with the thoracic region. And then we should be thinking about the inflammatory. Always we know the constant pain, and which will cause a disturbance in the sleep, and we should not be causing them any kind of a disturbance in the sleep. So if it causes the disturbance in the sleep, you can think about a constant pain, and constant pain which will be a more of an inflammatory. And then the fractures, which could be the stress fractures, are very common. Like we would have come across a lot of people having the stress fractures, and I've seen a lot of cases after the fracture coming to us for the rehabilitation of the the exercises or the movement which we need to look at. So please don't forget cardiac myocardial ischemia. So we are talking about patient feels that it's a more of a cardiac, and the pain was during exercise, and it's not reproduced by palpation, and it's not all the factors, the prime factors to say, because definitely they have to do the investigations for the same, like ECG or further things which has to be taken care. And thoracic aortic aneurysms or peptic ulcers. Peptic ulcers, they will have indigestion and pain with cystitis. They will have a nausea, vomiting, fever. And neoplasms, as we all know, like the one of the contraindication for mobilization or manipulation is unexplained weight loss. So where we are not supposed to do mobilization. And inflammatory like ankylosing spondylitis, if you try to remember, and then the fracture cases which has to be considered. Right. So getting back to the thoracic region. So as we all know, like we have 12 thoracic vertebrae, but it has got 126 joints. Okay. Are we going to mobilize all the joints? So is that going to change the movement? So that's what what you're going to see here. Like, and you could consider, like when I say patients who have radicular pain, like which could be, or you would have had about intercostal neuralgia, or people having a radicular involvement. There are various factors which can cause us a radicular pain. So maybe post surgical, and intercostal neuralgia is the one which we do, like we where we have the ribs in between, and we try to do the movement, that we try to identify that whether it causes or whether it really helps them to understand that. So intercostal nerves which can cause us discomfort to the person, which will lead into the intercostal neuralgia. So this is another case you would have walked through in your practice when you are looking about the thoracic region. And yes, as I said, yes, thoracic spine has got 12 thoracic vertebra, and it has considerably, like it's a kyphotic. So that's the reason, like when the kyphotic is more, you can't get the shoulder movement, or you can't get the neck movement. So even though like directly thoracic mobilization is not needed, indirectly it helps for the shoulder pain, it helps for the neck, and it helps for the back region, even though directly we don't have any kind of involvement. So that's what I would always say, something called a relative stiffness or relative flexibility. Okay, so this concepts which we need to remember. Relative stiffness is what happens is when you have a kind of shoulder movement, or when one joint is moving more, the other joint look, a little bit tight. So that's what we need to remember when we talk about there is a scapulothoracic joint mobility is good, whereas the shoulder joint is tight, and relatively here, thoracic can go for the tightness. So where we need to do a mobilization, even for a frozen shoulder or any other condition which you can consider, or even a rotator cuff impingement. Yes, we have plenty of joints. That's what I told you. We have 126 joints, which is present in the thoracic ring. Okay, so lot of joints which covers that. So posterior intervertebral joints, and you could see here, like this is the big area which we talk about our mobilization. So I would, look upon here the spinous process or the transverse joint, which is very important for me to do the mobilization, and as well as the intervertebral joints. So these are the areas which we likely to look in or try to reach or try to mobilize the person. So we should have a clear-cut idea, like where the line comes from. So as we all know, like when we talk about the levels and other things, indirectly, we should be able to have an impact on the presentation of the other structures, because costovertebral joint, which is deeper inside, it cannot be reached by, but at the same time, like where we will be able to reach to the costotransverse joint, where we'll be able to do the mobilization or the manipulation for the same. And the ribs, we have plenty of joints which talks about which get oriented, like costotransverse joint or sternocostal joints, intercondylar or costochondral or sternoclavicular joint has to be considered, or has to be remembered when we talk about thoracic spine. So that's a point in which why I have put across all these things, because sometimes what happens when we think that if there is any kind of dysfunctions, like for example, people who have a costochondritis can have a pain, a symmetrical pain on the anterior aspect, where the concerned level, the thoracic spine can be mobilized or can be done with that in the same position, so which can be helpful for the costochondritis, apart from our the normal conservative therapy. So you also have to think about, like when we have movements taking place in the clavicle, so most of that happens around that region. So when I do the shoulder movement, or when I do the neck movement, that is a big movement which is taking place in the thoracic region, has to be considered. So that's a mandibular sternal joint, sternal joint, and all this joints. So the point here is, don't leave anything, like starting, as I told you, cardiac or visceral, and as well as you don't talk about the thoracic spine joint alone. You have to consider the rib joints and other things which has to be taken care, like. And one of the main important thing which we need to remember is the kind of the innervation which we always look upon. So we have intercostal neuralgia, so the intercostal nerves which could be causing it, or causing the pain or the symptoms. And as well as we talk about various factors which has to be considered before we, that's because of the integrity and because of the compactness of the spine, we don't get a lot of or we don't get a disc involvement in the thoracic region much. But like we can get other pain, like musculoskeletal pain over this. And we have to consider about all these presentations which could be causing the kind of innovations. That's what we have, the synovial nerve which supplies the dura, or all these things which could be causing, or which could be the source of the symptom. So when we say the source of the symptom, which could be the structure which causes the pain or the discomfort to the person. So sympathetic trunk, and don't forget, we get, as I told you, the sympathetic nervous system get involved, so people can get palpitation, temperature changes, or as well as any kind of sweating changes. So this is the reason that the sympathetic chain is found very closer, or in a sense, like it's the osteophytes at the costovertebral joint. So the osteophytes at the costovertebral joints, the osteophytes at the costovertebral joints can compresses the sympathetic chain. So that can lead into that, and it can mimic immediately like cardinal sign, palpitation, which we say that it could be because of the cardiac involvement. So that's a very important thing which we need to consider when we talk in terms of that. So these are the location or the area in which where we have the sympathetic chain is found, and this can lead into the presentation of like any other thing like a palpitation, temperature, and sweating. So please don't forget to ask these questions to your musculoskeletal, thoracic, spine related patients, whether they have any kind of a palpitation, temperature changes, or sweating. So which could be due to the sympathetic chain getting impinged by the osteophytes. Okay. And yeah, so we have all these movements which comes in handy. So before we look for our mobilization or movements, we really need to know that what kind of movement or what kind of presentations which we are going to see. Like when I bend forward, or when I reach like this, hand up alone, it can causes the movement in the thoracic region. So when you consider about the movements, we really need to understand what happens over the. So we always look in with the PA glide, the posterior anterior glide, in order to increase or in order to get the flexion and extension of the person. So either the flexion or extension, we are going to do a posterior anterior central PA, or the straight forward, which we do on the spinous process. So we are going to do on the spinous process to check the integrity of the movement, or integrity of the technically, like whether we have any kind of discomfort or not. And if at all, if you talk about the costotransverse joint. Okay, so costotransverse joint, you have the upward gliding movement. So you got to do upward gliding at the costotransverse joint in order to facilitate the flexion. So if you want to facilitate a flexion, you got to do a central PA, and you got to do a upward gliding, or kind of superior glide over the costotransverse joint. So that's point which we need to remember when we talk about the flexion. And here the extension, as I told you, flexion extension. So still we are going to get the movement of the same thing, like when we do a flexion movement, or when you get an extension movement which is happening in the thoracic spine. So here we could see that, like when you do a flexion or extension, so it's all happening over the all the joints. But when you look upon our reach, we are talking about the reach as close as possible to the spinous process. So we should be able to reach to the spinous process and then try to do the central PA. And this is the place, like where we think about the costotransverse joint, where we are going to do the upward and the downward gliding for flexion and the extension movement. So which is very important in terms of if you opt to go for mobilization, or if you opt to go for a manipulation, we really need to understand this segmental movement. Okay. And lateral flexions, yes, of course, when you do a lateral flexion movement, because of the ribs, there will be passive insufficiency of the ribs, and which doesn't allow you to do further movement. So obviously there will be a rotation. That's what you get with a couple movement. So we talk about here, like when you do a lateral flexion, or can we get in, because can we get in any kind of discomfort, or it could be from the opposite side, or it could be from the same side, which could be caused by the compression or the distraction of the segment. So which we really need to know that, like is that the pain which is caused because of the compression or the distraction when you do the lateral flexion movement. So rotation, as I told you, like, always, everyone, give a pressure and then do the movement of rotation PA or rotation PA thrust. That's a manipulation which we, all intend to do, or we all would have learned that, which we can be done from T4 to T10. So this is, we are trying to cause tension in the costal transverse and costovertebral ligaments, and which causes the screwing up of the vertebra, so which literally causes a lot of changes in it, or which causes a lot of impact on the person. So these are the prime movements, as we all know, like the flexion, extension, lateral flexion, and rotation. So I would think about the central PAs, or I would think about the movement which we are going to do on the costotransverse joint. So that's what we are making a working hypothesis. So when I assess the flexion extension, okay, flexion is limited. So flexion is like when you ask them to do this movement, when the flexion is limited or the extension is limited. All right, okay, let me think about, okay, let me do a central PA, or let me do a the costotransverse joint upward gliding, or a downward gliding. So that's a working hypothesis we need to make when we go through this biomechanical structure. And it's very simple when you talk in terms with the treatment. Okay, so there are because today's world, we are talking through with subgrouping or classifications. So we are talking about a lot of subgrouping or classifications. So you should be considering about this same. So like we are going to talk about thoracic hypermobility. We can have a group which has got thoracic hypermobility. Okay, so there is a dysfunction or limitation of the range of motion of thoracic region. So you're going to ask them to do a flexion, you're going to ask them to do extension, you're going to ask them to do a lateral flexion or rotation. If they are limited, then you say that, okay, they have thoracic hypomobility. So if they have a thoracic hypomobility, what's your treatment? Okay, thrust manipulation to the upper, middle, or lower thoracic spine. So depending upon the area, okay? And non-thrust, central or unilateral manipulation. So that's a mobilization which we can do to the spinous process, transverse process of the ribs. And as well as, we can do a thoracic spine, self-stretching exercises to increase flexion or extension. Okay, so these are the possible interventions in terms of mobilization. So that's a one category or one kind of classification which we get. That's a straightforward. You are not able to get the movement of the thoracic region, then you are going to do a manipulation or mobilization. This is straightforward, a treatment technique. And if you have thoracic hypermobility with neck pain. So I have a neck mobility, okay, and assessed like I have a pain in the neck region, along with I have a thoracic pain or thoracic region range of motion restriction. Then you got to do this manipulation again to the same thing, and as well as you will be doing the cervical spine active range of motion exercises. So you're going to do this, or why you are going to do this, it's because of the relationship of the attachment of the muscles, and as well as because of the chain of movements which takes place in this region. Okay, that's a straightforward again when you have thoracic hypomobility with neck pain. And the next one is thoracic hypermobility with the shoulder pain. Again, you are going to do the same thing, but you are going to build up, or you're going to strengthen the surrounding structures, or whichever muscle, because we are going to, when you talk about a muscle, I would likely to palpate it. I want to find out the length of the muscle. I want to find the strength of the muscle before I conclude that which muscle has to be strengthened or which muscle has to be stretched. So we are not going to conclude that you do on this or you do for this muscle. So we really need to examine, evaluate the same, and then try to find the reason for why they are, which region which is involved. And then the people with fracture cases, we can think about doing a mobilization after fracture, after healing, after the everything is set right, you can think about doing this mobilization. And it's not necessary always, okay, because the other exercises are much important for this group of people. So if you say, okay, with the thoracic spine, this is straightforward thoracic hypermobility, where you do all the mobility or mobilization, and thoracic hypermobility with the neck pain or shoulder pain, you got to do the mobilization or manipulation. So this is because it's sometimes it's interesting, because we got a lot of subgrouping for the lumbar, we got subgrouping for various conditions started coming up. So definitely, we should be looking forward to think about the subgrouping in the thoracic region also. So this is a little contribution from few people, and this is where, we have to consider, or we have to think about uh, neck and the thoracic region. So when you have a cervical disc, or when you have a cervical facet joint involvement, it can cause us the pain down here. So that's the reason, always a facet joint or a thoracic or a cervical disc can cause us pain in the thoracic region. So if you have any discomfort on the thoracic region, doesn't mean that, okay, we got to do like a thoracic region mobilization. It can be a cervical region. So that's what we all know about the differential diagnosis, or we have to really look in with various structures before we conclude that, okay, it is a thoracic region. So not to forget, you can see here, C3, C4, or C5, C6, this can cause us a pain on the interscalpal regions. And always, people think about, okay, a rhomboides I got, and we got a trigger point, let me work on that, right? Or you do something else, or can we do a manipulation of the thoracic region? It's not that. We have to check the cervical region. So it's a kind of a cautious move, which we need to consider, before we think about the same. Okay. And this is where, I was talking about, what could cause the radicular pain, intercostal neuralgia or neuralgia of the abdominal wall, of various structures which can cause us the radicular pain. So dear friends, please don't take it easy. Thoracic region, okay, let's mobilize, manipulate, or do the things, but we really need to consider various factors before we get into that, or we really reason out, we really need to make the decision properly before we do the manipulation or mobilization for the same. Okay, so we are going to do the examination part, and when you do the examination part, okay, not to forget the subjective questions or the physical questions which we need to ask. So not to forget with the breathing. Okay, so breathing can have a inspiration or expiration can causes a compression or distraction of the joints in the thoracic region. So people will have some kind of a discomfort along with the breathing, so which could be telling you that the costal joints are involved. So we really need to mobilize the costal joint, and not to forget about upper limb dysfunctions. Okay, as I told you, scapula or any kind of muscle weakness, which also causes the same, or which also causes the discomfort to the person. So which we need to consider. One of the best example I would say always, or we all would have come across, is the T4 syndrome. Okay, so T4 syndrome can causes the pain down to the limb. So which we need to consider, and all the other questions are the same, for any other spine region, rotation activities or flexion activities or sneezing or coughing or and very important, which we talked about, the sympathetic function, palpitation, temperature, and sweating changes, and the symptoms related to the visceral order. That is what visceral disorders, what are the other conditions or other structures which could be causing the pain. So these questions need to be asked. This question need to be memorized. This question need to be put on to the patient to find out what segment you're going to choose to mobilize. And this is a beautiful picture about the visceral refer pain system. So you can have a patchy areas, like when you talk about the back region, or plenty of visceral organs can cause us the discomfort here. So please be aware of it. Always consider that before we think about, or we before we conclude that okay, this is a MSK or a musculoskeletal thoracic pain patient. Okay, and already we talked about this, the visceral organ, and then the palpation comes. So you're going to put the person prone lying. So when I say like acromioclavicular joint, T1 comes, T2, T3 comes at the spine of the scapula, and T7 comes at the inferior angle of scapula, which all of us know. So we use a finger, index finger, to palpate the same, and then keep moving. Okay, keep moving to find out the process. And for our comfort or for our palpation purpose, we can divide into three groups: T1 to T4, and then T5, T6, T7, T8, and T9, T10, T11, T12. So all this can be looked upon differently, or all this can be taken care. Like, when you talk about T1 to T4, the spinous process are like widespread. Okay. And when you say with T5, T6, T7, T8, it is narrowly packed. So it's like this. And then, up here, down here on the lower segment, it's up like the lumbar region. So please try to remember that. You could, get an idea, like, what I'm talking through. So 2, 3, 4, 5, 6, 7. So you have 1, 2, 1, 2, 3, 4. So these are widespread like this. Okay, widespread like this. 1, 2, 3, 4. And then you see the 5, you see the 5, 6, 7, 8, which is inclined down, closely packed here. And then we have upright, something similar to the lumbar region. So something similar to the lumbar region where you can see, rather than a different thing. So we have, you try to make it easy, like remembering the three things. Like, this is what the upper four segments, and then the mid segment, it's narrow, like inclined then, and then the down segments upright like this. I'm talking about the view, like which you are trying to palpate here. So that's for the palpation. So you try to run through the spinous process, you try to run through the various segments which we have. So as I told you about the bony landmark, T1, or AC joint, or T2, T3 spine of scapula, or inferior angle of scapula, T7, which we will try to palpate, or we try to identify it. So palpation is good, because we very late now, we get a lot of various factors which comes across, saying that okay, the palpation is not necessary, or palpation is not going to tell you anything much. But we go on with saying that it's easy. If you are able to palpate the structures, we will be able to find the segment which you have to mobilize or manipulate. Okay. And please don't forget about the nervous system. So that's nervous system is continuum. Okay, so the nervous system is continuum. So not to forget about that. That's what, like when I say, like we have variations in the slump test. So we do a normal slump test, we do a sympathetic slump, we do a um, kind of position in which long slump test, or you can do a sideline slump test. So it depends upon need of the patient, or depends upon the the impact of the structures, where we have to do the slump test accordingly. So slump test, it tells you about the neural irritation, but at the same time, slum fleshing technique, or slum slider technique, which is very good. And I hope all of us would have gone through, like kicking a football. Like when I kick a football, like I do a knee extension and then do a neck extension, which can be a good home exercise program for someone with the nervous system involvement. Okay, so coming back with the palpations, various structures which could be palpated, the ribs and all these levels which has to be considered. Or if you remember, like from the spinous process here, two finger breadth distance, you have the transverse process. Okay, so that's where the costotransverse joint. So consider here, this is the spinous process. This is the spinous process, and then we take up a 2-finger distance where we get the costal transverse joint. So always, it's quite handy in order to know about, or if you go with the finger width, which is internationally accepted, rather than going with the measurement tape or centimeter wise. Yeah. So you should be probably palpating all these recurred things when we do that. And this is what we allow to experiment the patient with the help of the ultrasound scan to find the levels, to say that I am palpating properly or not, or am I, is that the same level which we try to do. So this is one of the studies which we, or one of the areas that we explore to find about the levels. This is for the D3 level in the lying position, what we try to do with ultrasound scan. And then in the sitting rest position, there is a little bit of a variations in that. That's what we just because this is one of the way, why I say about this is ultrasound real-time ultrasound is the best method to understand about the palpation of the structure. Okay, so if at all we want to learn more about the palpation, that's the best thing to do. So try to explore this on various things and other structures, plenty of structures which can be palpated, which has to be considered. So this is again, where you are talking about the radiations of the thoracic facet joint. Okay, so you can think about the T7, or even you can think about T12 can cause us the discomfort at the iliac crest, or you can think about the thoracic region, like 1 and 2 can cause the discomfort up over here. That's what we end up saying that, okay, this person has a supraspinatus trigger point. Okay, it could be because of the T1, T2. So consider that. Because only 5% of the overall musculoskeletal OPD we get thoracic pain. So it's not much, but even though it will be less here. Yeah. So consider that before we think about it. Okay. And then the movements. So this is what we do with the palpations, the active movement, the flexion. Okay. And then we have the extension, which we do. Then you consider about hand placement, which we are trying to find out the individual segments, what is happening over there. Then the lateral flexion, and as well as the rotation movements. So this is what happens. This is what happens or moves around inside. Okay, so rotation. So you can always see that by finger placements, which is trying to find out the segmental mobility. So that's what we are trying to do. Okay, and of course, if you're not able to find out in the active movements, you go for the combined movements. Then we do the passive physiological movement, all these rotations, flexions or extension, which has to be done. So this is what the hand positions for a lateral flexion can be done. But I don't want you to do a passive physiological movement. It is rigorous, or it is very difficult to do the procedure. So you always keep off that. Coming back to the accessory movement, which is main fold for our mobilization or manipulations, right? So you have this central PAs, which you do, or you have the central PA for upper thoracic. We do it from the head end, okay, using the thumb, which can be done better, or you still you can use the pisiform grip to do for the mid segments or the lower segments. And that's what you do with the pisiform grips. We'll not be able to see that. That's the reason I put across with the help of the thumb. So I would request you to use the pisiform grip to do the same. And then you have the unilateral posterior anterior pressure, which you do it over the transverse process, and as well as and the PA over the ribs, which we can do, or the mobilization over the PA, and as well as we can do a lot of movement in the various positions. So this is what I'm talking about: the superior glide, the costovertebral or costotransverse joint. Both moves together. So we are talking about, like, in order to get the flexion, you have to do the superior glide, so which has to be kept on the. So this is where you have the spine, and this is a place where you can keep, the fingers, so you can do the movement up in order to get better the superior glide, or you can do the rotatory PA. This is what everybody is interested. Everybody is aware about it, and as well as we are familiar with this, the rotatory PA thrust. Okay, so if you have a facet joint involvement, facet joint pain, this can be done. Yeah, the transverse vertebral pressure as a part of assessment, we can do that, but it's not much significant. Okay, it's not much significant, but we can do that as a part of a assessment, and if needed, we can do this. So this is a wedge which can be used for costochondritis or any other person who has anterior pain. You don't want to, we can't do the mobilization over there, so you keep on the over the wedge position. Okay, so over the wedge position where you keep the spine. So the person is lying down over here on the supine lying, and the spinous process goes into this, and then you probably, you keep a towel over here, and we can push it from anterior. So that's what we can do with using this wedge. And this wedge is a multi-purpose one, which can be used for various things or various, regions. So not only with the thoracic. So this is one of the area which we need to look upon. And a lot of, evidences are there pertaining to the treatment for various like the thoracic spine mobility. So you have plenty of evidences which supports. But I would say that clinically, yes, we apply that. It is useful. It is helpful. So definitely we can go ahead with that. So you have a lot of evidences for the various presentations in the thoracic region. And of course, you do have a manipulation which we can get in. So this is the position in which we can put in for C7T1 localized lateral flexion manipulation. So that's a procedure which is called, because if you have a limitation at the C7T1, which could be because of the neck region, where we can think about doing this. And this is the position in which we put in here. So you can have one hand, one thumb on the side of the spinous process. Either you can choose C7 T1 or T1 T2 level. So you can keep it over there, and then you keep one hand up and another hand down. Okay, so the person is going to rotate the neck to the side, and then you are going to keep the other hand on the zygomatic arch. Okay, so you're going to keep it on the zygomatic arch, and then this is the one which is going to be causing the mobilization or manipulation, rather than this. So this is the one which is going to be fixed. Okay, so this is going to be fixed, and this is going to do the manipulation. So this is the one kind of thing which you do, and another one is the T4, T5 manipulation, which all of us are familiar with. Like you keep it over the transverse process, and then do the give a PA, and then rotate it, try to feel that movement, and then you synchronize with the breathing, and then do the manipulation. But when you do manipulations, the biggest question comes: do we have a contraindication? Yes, of course, we have lot of contraindications for the same, like body issues or any pathologies that have led to the body compromise, tumors, infections, metabolic, congenital, and corticosteroid injections, or osteoporosis. Definitely, we are not going to do that. Spondylolisthesis, hypermobility, and we can keep on saying so many contraindications for the manipulation. So I would, say that you you have to be very careful, very cautious in choosing, what you want to manipulate. So it is not all about everything, but you can manipulate, you can mobilize, but try to identify that. So this is my take-home message for all of us who want to do the manipulation. Manipulation can be a useful tool for physical therapists in conjunction with corrective exercise, despite the poor research on long-term outcomes when performed as a sole treatment. Okay. Manual therapy should be used as a supplement to corrective exercise to help get patients better and make them more responsible in the care. And it's very important for us to know that, what happens or what really. And if you are not proficient or confident in performing manipulations, don't use them, which is very important. Please keep it in your mind always. There are many alternative ways to mobilize a joint besides using manipulation. So you can mobilize, you can do a lot, and be aware of yellow flags, psychosocial factors in performing these techniques, and consider you know the neuroplasticity or the neurometrics or the pain control theory if you really want to do this procedure. And that can be a strong placebo effect, because we got the sound. Because I had a patient who came to me saying that, can you crack or can you do make a noise? Okay, so within a second we got the noise and the patient is happy. And so you do end up having patients like that. Manipulations may provide quick relief of stiffness and pain for patients with facet dysfunction. Quick relief, instant relief, okay? But long-term, always less exercise are better. So we are in the business of helping people function better, but also feel better. So this is the note, which I want to tell across to you. And if time permits, we have here the case report of one of the cases, where you have a lot of pain over the various structures, and you have the clinical prediction rule, which says that what or whom has to be manipulated. So these are the things which we need to look. If they go on with this, okay, then we can really manipulate thoracic region for neck pain. So this is kind of a recipe kind of a thing, or to make things easier, we have this clinical prediction rule. So hopefully, we need to get into more and more of this to get a better idea about what we are doing. And these are the people to follow up regarding this thorax region. So Lee, so Dan Lee, who is a pioneer in the pelvic region and as well as thoracic regions, and Joe and Dan Lee here, and then we have Edmundston. So all these people, studies or books or literatures, you really need to follow through. Okay. And then Jenny McConnell, who always says that thoracic has to be mobilized for best or to get better in the back pain. So that's what and not to forget about the Hodges, who talk about various muscle and as well as core which core stability, which we talk about for the lumbar region. So same thing, he talks about for the thoracic region, so which has to be considered. So these are the various references. If anybody really want to have a look at the literatures available, you can really contact me, and you can WhatsApp me, we can reach to you, we can send you the articles which might help you. Yeah, thank you very much. If you have anything to be asked, anything to be heard, you are most welcome. Hello. Hello. Hello.
Hello.
Yeah.
Hello.
Yeah.
Yeah. Good evening, sir.
Yeah. Good evening.
Sir, good evening.
Yeah. Good evening.
Shomu sir is there? Hello. Hello. Shomu sir is there?
Yes, madam, I'm there. Yes.
Okay. Okay. Okay.
Yes, yes, I'm there. I'm there.
Okay. Okay.
So the first question
Yeah.
for you,
Yeah.
what is the rule of three in thoracic spine?
What is the rule of three? Okay. I don't know. What is that rule? A rule for me. Okay. Uh, so severity, irritability, nature of disorder, and specific pathology. So I always look into this. I think about cardiac. I think about the visceral organ before I jump into MSK. Okay. So maybe I can look around for this rule of three, but I'm not come across anything like, because we have a lot of fantasy names which come across this. Yeah. Yeah. Next question.
So 1 second.
Yeah.
So one question from Dr. Avinash. Can we give those glides of mobilization or giving grade 5 mobilization, which will be better for kyphosis and scoliosis patient for the change of alignment of the vertebra to normal?
To normal. Okay. So if you think about kyphosis, if the angle, which goes beyond 30 degrees, the corpse angle, which goes beyond 30 degrees, we can't do anything with a conservative management. And you can go ahead with a lot of mobilizations. But I really wonder, like, uh, how people mm, yeah, how people correct by one sitting manipulation the deviated spine. It's a bit strange for me with my experience. Okay. But I heard or I see a lot of people putting in social media saying that, like, by doing one movement, they corrected the scoliosis or kyphosis, which is really strange for me, and which has to be done along with a lot of exercise. We have a big and good set of exercises for a scoliotic, thoracic region, which has to be reached much better rather than doing manual therapy. That is my say. Yeah.
Okay, sir.
Yeah.
So next question is from Dr. Pradeep Kumar. In case of ankylosing
Yeah. It's a
spondylitis, is it
contraindicated. It's a contraindicated.
contraindicated? Okay,
Yeah. It's a
okay, sir.
contraindicated. Yeah.
Okay. Next is from Dr. Bishmaya. How to mobilize thoracic spine
Mm,
if someone have
mm.
scoliosis condition?
See, scoliosis is okay. There are plenty of reasons why we get a scoliosis. We really need to look into the factors which causes the scoliosis. Rather than trying to mobilize straightforward directly to the spine. So if you look in here, like you have scoliotic changes in the curvature. So it's like you are not going to push it back, but there are various other reasons, like it could be a limb length discrepancies, or it could be a lung involvement, and plenty of factors. So all this factor has to be considered before we think about it. Yeah.
Okay. I would request everyone, if you have any question, please put in at the chat box now. Sir is answering to the question if you have.
Sir, one question from my side as well.
Yeah.
Sir, any practitioner or therapist who claims that actually the popping sound that gives a patient the correct alignment, is it true, or like is it common physiology, sir?
Can you repeat it again? Yeah.
Any practitioner or
Yeah.
therapist who claims that the popping sound actually giving the correct alignment, is it true, or
No. Popping sound. See, when you do like this, also we get popping sound, right? Does that give the alignment? No, not at all. Not at all. Hmm. It doesn't mean that.
okay, sir? Okay.
Yeah. Yeah.
So next question is will COPD symptoms are improved
Mm.
with manipulation?
There are procedures for that, like thoracic lift or
Okay.
PNFs. All this could be, could help the COPD patients rather than doing it with mobilization alone. Yeah, it's
Okay,
a
sir.
big adjunct like a rib mobilization, rib springing. All this can be done definitely.
So, will weight training can be combined with manipulation?
Well, weight training can be combined with manipulation. So what is the reason for that? You're choosing. We need to consider. So why you want to do manipulation? Is that because he has a pain, or is that because of he has some amount of discomfort? Then you can choose manipulation with anything. It doesn't matter. But before you do manipulation, you really need to find out a lot of factors has to be considered.
Okay,
Yes.
sir.
Yeah.
Okay, sir. Thank you
Yeah.
so much. Actually, like we all the Tripura IEP team would like
Yeah.
to thank you so much, sir, for this exclusive kind of webinar. Like you have presented it very well. Like we came to know about the theoretical and both the practical thing. So many like demonstrative pictures you have given to us. Like it is a great opportunity. I know you are a very busy person. Like it is very thankful. We are very thankful, sir, for giving us time. And many things we have, like we should know that if we do not know the mobilization very keenly, then we should not apply it. Better not to affect the patient. We should have good knowledge about the manipulation. It's a good treatment. It is really very effective treatment, but we should get all the knowledge before applying it.
Yeah.
So
Yeah.
thank you so much, sir, from like
Thank you to all the people with Tripura CEC and Soumya, Upanita, and
yes, me
Dr.
Upanita,
Jaspreet and
coordinator
Dr. Kumar and everyone.
coordinator from
Yeah,
Omen, sir.
Upanita. Yeah, yeah, and yeah.
Thank you so much,
Thank you very
sir.
much.
Thank you
It's my
everyone,
pleasure to
every
share my knowledge
participant.
with you all. Thank you. Thank you.
Yes, sir.
Thank you very much, sir, for your valuable time, sir. Thank you very
Thank you.
much.
Thank you.
Thank you, Paulson sir, for such wonderful session, and thank you, Tripura IAP State and Women's Cell team for organizing such wonderful webinars. Thank you.
Thank you. Thank you. Thank you, Doctor.